give us CME for this presentation. I repeat that unfortunately there is no CME for this presentation because it is too far out for them. But we're going to be on the cutting edge with Dr. DuPree today. And here she is to talk to you about psychedelics.
Wow. I guess my academic appointment to Penn is probably going to be taken back too, so I got to stand over here so I can. Hi everybody, whoever's on Zoom, everybody who braved coming into this room to talk about this topic. I have been on a journey for the last 35 years of my career, and sometimes you don't know where the journey is about to take you, but I'm going to share with you today how I got to where I am in this world of talking to you about psychedelic therapy. This is not a psychedelic journey, this is the view from my porch. There are a few people in this room, Bill Scarlett, Carrie Grumman, Dr. Lynn Dever, Cass Egan, who've been to my porch. The rest of you are invited to come and see this beautiful view as well. This is Sedona, Arizona at night, and that is what the Milky Way that's flowing over the top. So, psychedelics have clearly pushed people's buttons, and I'm hoping to send this to most of my colleagues that I know from Penn, just so they understand where I'm coming from with this and where I hope to go with this, particularly in cancer care. These are my disclosures. And I'm going to break this down into my journey, because you need to understand why I'm up here talking to you about this and not in the operating room full time anymore. Talk about a little bit about the history of plant medicine, because I didn't know the history of plant medicine before I started. I didn't know what ACEs were, and I particularly put this up there as ACEs because some of you may not know what ACEs are. And then we're going to talk about depression, anxiety, PTSD, post-cancer pain, and how we can find alternative treatments for it, and then the current research that's ongoing in psychedelic therapy. So first and foremost, this is not an endorsement to go out and do illegal substances. Psychedelics, both plant medicines and synthetic, have gotten a bad name over the years, but what I'm talking about is the utilization of psychedelic therapy in clinical trials and potentially in clinical utility, which is probably about anywhere from 18 to 20 months down the line from where we are right now. So set and setting is very important. The preparation before the journey is important. Having a trained sitter to be there for the journey. And then really the most important part at the end is the integration. It's kind of like, what did you learn from that? It's kind of like doing a root cause analysis where you're actually going back to figure out how to put the pieces back together and be able to repair the past. So I am not supporting recreational utilization of psychedelic therapy. You'll hear that again later. So this has been my journey. I've trained at some very fine institutions, practiced at some very fine institutions, but along the way, I have been very, very focused initially on treating cancer with surgery, chemo, and radiation therapy. Most of you know the part of my journey about healing and the work that I do with my foundation, which we're going to have our event Friday night. Quick plug, if anybody wants to come, I can still get you tickets to the Humor for Healing. But along this journey, there have been some constants that I haven't been able to take care of. One of those is the fact that depression, particularly breast cancer, looking at 72 studies globally, 1 out of 3 women suffers from depression. And some of them, it comes after the cancer, some of them, it's before the cancer, it gets exacerbated. But 30%, 33%, that's way too high to ignore it. The global prevalence, this is just not a Western medical issue. In India, 21%, China, 13%, Malaysia, not 22%, and all of these have led to a decrease in the quality of life. And I've said this all along, when we get someone through a cancer journey, but they sit in their kitchen with their lights off waiting for cancer to come back, we have maybe cured a cancer, but we have not healed that individual. And that's really what I'm talking about. Cancer brings about an existential crisis in every single person that's diagnosed with it and every loved one of the person that has cancer, because even though we know that none of us are getting out of our life alive, it becomes a very, very stark reality because the word cancer brings that to the front. And this existential plight is something that we don't really deal with well in Western medicine. Clinical studies have shown that 80% of women that go through breast cancer end up with PTSD. Flashbacks, feelings of emotional numbness, outbursts of anger. I've always say, it's not the milk that gets dropped on the floor that sets someone off. It's that trigger that brought them back to that place. And every single device company that Dr. Scarlett and I have worked with over the years, we have asked them, could you make us a tool in the operating room that cuts out fear when we cut out cancer? Because it is that fear that paralyzes and prevents our patients from moving forward with grace and ease. So I grew up I was born in 1961, and I grew up with many of you that LSD is evil. It is the evil drug, and it needs to stop at all costs. And then I read this book called Food Rules, because I think Bill Scarlett recommended it, and it was about nutrition. And I thought, this is great, because we are all about preventing cancer risk recurrence by changing nutritional boundaries and nutritional guidelines. So I was pulling off slides for a talk in 2020, in the end of 2019, and I pulled up Michael Pollan's book because he's a really good writer on nutrition. And on the internet was his next book, How to Change Your Mind. And I didn't actually read the fine print, I just saw How to Change Your Mind. I thought it was How to Change Your Mind about food. And I said, if he's got tips for me to get my patients to eat better, I'm all in. So I downloaded it on Audible without really looking at it, and started listening to it on the way to work, and I'm like, this dude has lost his mind. He's talking about LSD and psilocybin, and I didn't even know how to spell psilocybin, and I didn't know it was a magic mushroom, and I didn't know that MDMA was ecstasy, because I literally I was born in the family of no drugs. So there you go. Well, fast forward, I will tell you that once you see, you cannot unsee. Once you recognize what we have in our midst that we can potentially utilize for our patients, I can't go back. And then I talk about my personal practice, where I had my so-called arrhythmia of the soul, where I went through my own challenges in another health system, not this health system, love this place, but it was that process of the arrhythmia of my soul that got me to where I am right now. And there's actually a great Netflix series, if you want to watch it, called How to Change Your Mind, in case you're not into reading books, but it's a fabulous series. But that was the beginning of me opening up a book and saying, wow, so the guy says that psilocybin works. Show me the data. Show me the clinical data, because I am a Western trained physician and I need to have proof that things work. So here I am at this point in my life. I've, over the past 2 years, studied with California Institute of Integral Studies, studied with MAPS, currently studying with Synthesis. My class is meeting without me right now because they're in Amsterdam, so it's kind of weird timing. But I am on a journey to learn the most I can about plant medicines and psychedelics, because I believe that in the appropriate set and setting, they have a place, particularly in cancer care, and we actually have some opportunities currently in cancer care. So I am not here to change your mind. Got it? I'm not here, that's Michael Pollan's job. I'm just simply here to open it and I don't know, Janet, if you send that link down to Penn, but maybe somebody's watching just to see how far out there I am. So hi everybody from Penn if you're watching. So I thought I'd start by looking, I know Mike Lane is shaking his head going, I can't believe she's saying this. But Mike, you know me. I wanted to look at what are healthcare workers' perceptions of this, because if I'm going to bring psychedelic therapy into a clinical setting with my colleagues, I gotta know, what are you guys thinking about it? So there was actually a trial done that looked at healthcare workers to determine how well we could incorporate psychedelic therapy into care. And the most important thing, Jeanette's gonna be happy, efficacy and safety. It's about how well does it work and how safe is it, because we don't want to do any harm on our watch. So then you get into the place of looking at other populations, because some of these plant medicines have been utilized for thousands and thousands of years, and we are very new to this. So instead of doing what we've done many times, which is take stuff from other cultures and try to plop it into Western medicine, what do we learn from those cultures, and how best can we take that and assimilate it? And so, it's important to also talk to cancer patients, who are the biggest stakeholders, they're caregivers, and looking at palliative care, which is where all of the original research was done. The original research in psychedelics and cancer was done on end-stage cancer patients, because they were looking at some way to alleviate their existential crisis. We also have to look at our spiritual leaders. We got to talk to the nuns. I'm planning on talking to them Friday night if they're not here in the room today. And then we have to look at our health systems as a whole and say, is this going to disrupt what we're doing, or is this going to enhance what we're doing? So an entheogen is defined as something becoming divine within. And it is considered a substance that brings about a non-ordinary state of consciousness. And so I like the word entheogen because it's less triggering than the word psychedelic. Psychedelic has we're going back to the 60s and we're going to go to Woodstock and people are going to be dropping acid, and that's not what this is really about. This is about looking at entheogens and how we can utilize them to improve the quality of life of individuals who are suffering. So these are some very common entheogens that you may not even know about. Morning glory, kava kava, fly agaric, which is a mushroom that has a very similar, one has a psychedelic property, the other one's not so good for you. Salvia, LSD obviously, San Pedro, which has been used in South America. It is illegal, it's illegal in the United States to use as a entheogen unless you are part of a Native American tribe. Iboga is an amazing compound that is found in Africa. And Iboga is being used in clinical trials for heroin addiction, which is not an easy one to break. Also refractory alcoholism. Psilocybin, which is my personal favorite for cancer patients, which is where I believe I'll be doing my research. Peyote, again, used by the Hokel Indians in Mexico. It's legal for Native Americans to utilize it in their ceremonial practices. It is illegal for anybody who is not of Native American origin to go pick a peyote button and take it. It's not illegal if you happen to be Native American. And then there's the mother of all entheogens, which is ayahuasca. Ayahuasca comes from South America. It's a brew between a vine and a leaf. And there's multiple vines and multiple leaves, so there's a lot of different types of ayahuasca. Different ones can bring about different journeys. A lot of people are traveling to Costa Rica, to Peru, to Brazil to get access to this, where it's legal in Mexico as well. So these are what I'm talking about from a plant perspective. And then we also have MDMA, LSD, which are our synthesized entheogens. So indigenous ceremonies is where this all started. So this is about taking this back to the roots. How do we learn what these medicines have the opportunity to do? And they're called psycho-interrogators. This was a term that was coined because the individuals in the community would go to the shaman. They wouldn't, the individual wouldn't take the medicine, the shaman would take the medicine. And the shaman would take the medicine and go on the journey to bring clarity and healing to the individual that was there. And that was done for years and years and years. And this is where, you know, I know that in current practice, and I was kind of surprised, and I think a lot of you know it, I in my training, I did go to Costa Rica to do a legal ayahuasca ceremony. And I was really surprised that the shamans were drinking this stuff. I'm like, who's gonna be taking care of me? Like, if I'm gonna drink this medicine, but the shaman had to drink the medicine to be present with you in that space, because every different brew was different. And all I was thinking after I left, after 4 ceremonies, was, I don't know how these people do this every week. Like, I was completely wiped. But I shared yesterday with a colleague, for me, my greatest growth from that was, go figure, I needed to learn how to give up control. It was all about me letting go and surrendering, which is pretty much, I think pretty much every surgeon and physician has some of that. But what I got from that process was what the shamans were getting in the medicine that they gave to me in knowledge was really that gift. And this is where I want us to be really careful as we move forward with this in our Western medical cultures, that we don't forget that piece of what the healer brings into the process, what the shaman brings into the process. So you can go back and look at ancient art, thousands of years old. We see mushrooms, which were the sacred plant medicine, for decades and millennium. And they actually got the name Tiananacatl, which means literally flesh of the gods. So these mushrooms, which were sacred, cultivated in these communities, were savored as part of a spiritual ritual, not going out on a Friday night tripping with your friends. Like, this was about taking a journey with a healer to be able to gain that knowledge that mushroom has for the individual. Fast forward to 1951, this guy, R. Gordon Wasson, went to Mexico. He had heard about these mushrooms. He and his wife, who was a pediatrician, she was a Russian pediatrician, they went on this journey. And unfortunately, they didn't keep it to themselves. He published the story in Life magazine, and it was all over the place, and it was huge. And then the Beatles and all these people were traveling to Mexico. And unfortunately, Maria Sabina, who was this amazing, amazing healing curandero, her house was burned, her community was kind of trashed, because that was what happens when we don't have the respect for the medicine and the ceremony that goes along with it. I think everybody in this room knows what LSD is. It was created in a lab by Sandoz, which is now Novartis in Switzerland, in 1938. Laid on the shelf for a long time. It was created as a respiratory and circulatory stimulant. Then, 5 years later, the Albert Hofmann got some on his hands and clothing and started having this experience, and he actually rode his bike, because that's what you do over there. So his lab assistant rode the bike with him, and that was the first documented LSD journey. And for him, it was life-changing. And I think at that point, that was when, back in that year, that they were handing out LSD to everybody that wanted to try it and use it in their clinical setting, because they were seeing tremendous benefit for people that were taking these journeys. In 1971, Walter Pahnke wrote a paper that referenced all the research that was done prior to the massive shutdown in the war on drugs. And tens of thousands of patients were treated effectively with LSD, and they really had a very positive effect coming out of it. I honestly believe that the main reason that we had the war on drugs then was you can't really fight a war when everybody's peace and love and they're all dancing together, having their experiences. And one of my dreams would be to shut down Washington, lock the doors of Congress, give everybody magic mushrooms, and watch the kumbaya, because they could all be friends again and realize how connected they are. And that's one of the things that happens on those journeys, is they get a spiritual connectedness where you're connected to the person beside you and across from you, regardless of religion or faith or politics. And that takes away that desire to go out and fight. So research was literally halted almost completely for 40 years. And the war on drugs was real. In 1973, the DEA was created, and suddenly it was demonized. And it's sad that although they backpedaled on the drug, they didn't allow any of the research to go forward, because in the research and in the clinical trials are where we really find the truth about how well these medicines and plant medicines can potentially help us. And it's sad, I don't know that LSD is ever going to be studied that way again, because the word LSD it's too polarizing, it's too triggering, so I don't think that's ever going to happen. Stephen Ross is a psychiatrist from NYU Langone, great guy. He was one of my professors in my teaching. He went back and looked at the clinical research that took place between the 1960s and early 70s, and it looked at treating cancer-related distress. And so he did a systematic review from 1960 to 2018, 10 trials, 445 patients. 6 open-label trials found that what they were able to clinically prove was that, beyond a shadow of a doubt, they were able to get rapid, robust, sustained improvements in cancer-related existential disease. And we're talking about depression, anxiety, fear of death, the things that paralyze our patients, the things that I say that we cannot cut out with our scalpels. So a few months ago, we were in Chicago teaching a course to young breast surgeons. And as I was listening to one of our speakers, who's going to be a speaker on Friday night at our Humor for Healing event, I realized that a surgical trauma from her early childhood was what the real issue was, that she had not ever been able to face. Nobody had ever asked her about it. It made complete sense about why she had such fear around the surgery itself. And before I did my training in psychedelic therapy, I didn't know what ACEs were. You guys probably do, because I don't think a lot of surgeons study adverse childhood events. But it's a 13-question questionnaire that looks at physical, psychosocial, sexual abuse. What is really amazing is when you actually look at the real scores, the incidence of cancer, depression, suicidality increases as the score increases. There were 12 studies that were looked at. 5 found significant association between adult cancer diagnosis and ACEs. It's not something that I've ever asked a patient on an intake in the office. Like, I've never asked them to take those 12 questions to see what those ACEs scores are, because when we talk about risk factors, I don't know that any trials have been done to look at modifiable risk factors. Like, can we help patients heal from those traumas to decrease their risk? And that's something I think would be really fascinating to be able to do. So this is the staggering truth is, if someone has an ACEs score of 4 or greater, they have a 200% increased incidence of cancer, depression, 450 of depression, and 12,000% increased risk of suicidality compared to people that have a score of 0. So this is where, some people say just put the past in the past, but for some people, that baggage that they carry along is very, very heavy baggage and impacts other aspects of their life. So depression is one of the big side effects that we see in our cancer patients. This was a study done that looked at 21% of 230 patients, average age of 53. 22% of them, 1 in 5, had moderately to severe depression. When I've gone on medical missions to Haiti, there was a saying, "Santé c'est richesse," which was, your health is our greatest of wealth. And when you don't have health, you don't have anything. But our mental health has to be a priority, because no one's going to be physically able to maintain their health and well-being without mental health. So I think the saying needs to change, that our mental health is our greatest of wealth, because we focus so much time on treating the body. And something I learned through my leadership courses here at Redeemer is there's 18 inches between your head and your heart, and that's the longest distance for things to have to travel. And I thank the sisters for that education, because that little piece of knowledge of knowing that somebody, if they can't feel it in their heart and they can't know it in their head, and those don't connect, we miss that opportunity for deep healing. So here was this was like mind-blowing for me as I was going through my psychedelic training. There was a meta-analysis done for antidepressants for looking at how patients did with antidepressant treatment. So we're talking about the pill for the ill, depression, right? All different causes of comorbidities. In cancer patients, antidepressants only perform as well as placebo, showing that this is probably a different type of process, and putting someone on a pill to treat their depression, not only isn't it going to get better, but it can exacerbate or bring up other issues. So when we look at clinical trials that are done on psychedelic therapy, there's a lot of exclusions. Obviously, nobody should be taking a psychedelic medicine either recreationally or in a clinical trial. And I like to look at this as people that are doing recreational drugs, they're like on a tourist visa. And I don't think anyone should be doing psychedelic drugs unless they have citizenship in that country, where you're going to get cared for. People are going to be around you. You're going to have guardrails, because they're not to be played with. They're very, very strong, powerful medicines. So suicidality, pregnancy, manic depressive disorder, cardiovascular stroke, because a lot of these drugs raise the heart rate. Obviously, people with aneurysms. So the screening process is incredibly important. And this may be, these drugs are not really, they're not addictive. This is not like addictive potential stuff. Believe me, if anyone can get addicted to ayahuasca, you show me that, because that is not a process that you want to be doing over and over and over again. From my perspective, it's how we screen these patients. Just like before we do a procedure on someone or put them through something, we're going to do a very stringent medical screening. And this is why psychedelics are not for everybody. Psychedelic therapy isn't for everybody, but there are other aspects of this therapy, such as breath work, where we can still be able to bring a lot of patients into that place where they can get peace through this process. So this was the study that really did it for me. Roland Griffiths and Bill Richards. Bill Richards is a psychologist who had been doing research in Germany when he was in his training. His wife and he had moved to Maryland. They were doing research. They had 2 boys, and when his boys are in their early teens, his wife died of breast cancer. And I watched an interview with him right when I started reading about all this stuff. And he said in the interview, one of the things he really wanted to see before he leaves his body this time is research on early stage breast cancer patients to determine how, if we impact their outcomes, so stage for stage, grade for grade, because when they're done their Western medical treatment, most of these women fall off a cliff, and it takes a while to get back on the bus, and get back on the bicycle maybe, but, so that was something that just stuck in my mind because he lost his wife to breast cancer. Then he ends up becoming the guy that's interviewing me for my graduate program. Met him on Zoom, love him, and we're hopefully going to be working with the Aquilina Cancer Center in Johns Hopkins to be able to do that trial. I don't know, I guess I have to talk to Mike after that to see if he's willing to go out on a limb with Redeemer, but I know he's shaking his head again. I won't force you to do anything, Mr. Lane. No, this is research that it's got to be done in cancer center settings, it's got to be done in a place where we know that our patients are going to be safe, that they're going to be cared for, and this would be a phase 3 trial because there's already been phase 1 and 2 trials that were done, and what they showed, and these were patients that were stage 3 and 4 that were done in this trial, 78%, 6 months later, still had no return of their anxiety, 83% of their depression, 83% had no return of their anxiety. Those are unbelievable numbers from a single 3-hour psilocybin session, which had preparation, the appropriate connection and the sitters that were there for the process, and then the post-integration. And this is where I think we're going to be able to make the biggest shift for our cancer patients because, as I said, many of our cancer patients come in with the baggage from the ACEs, and this is how we can learn to unpack the baggage. In patients that had true, treatment-resistant depression, 50% of these cancer patients were able to have symptoms alleviated for months afterwards. There's a trial done on just straight old depression that was done by Robin Carhart Harris, and they're now out to 18 months with still sustained decrease in recurrence of depression. So one of our current dissociative drugs that we actually can use in cancer care legally every single day is ketamine. Ketamine is a dissociative. It does different things at different levels. At higher levels, it's a dissociative. At lower levels, it's more of an analgesic. They believe that it's been shown to increase brain-derived neurotrophic factor and dendritic enhancement or dendritic growth after treatment. So cancer pain is a very, very common occurrence. Ketamine can be used to treat chronic cancer pain where opioids, eventually the opioids, like you can continue to give opioids, but you're going to depress the respiratory cycle. So to be able to decrease the amount of opioids, you can add a small amount of ketamine. In chronic pain, it helps to decrease the opioid need. And then in that way it can increase the quality of life. This was a study in palliative care. This is recent, this is from 2015, which is why some of the other studies are now prevalent, is that 90% of our patients have cancer pain, 10 to 20% is refractory. It doesn't matter what we do to them. The opioids don't cut it. And so they started doing ketamine infusions of 0.2 milligrams per kilogram per hour. It's a continuous infusion, and it's more like a PCA, so the patients are completely conscious and with it. They're not having any dissociative issues, but the analgesic mechanism on the NMDA receptor is such that it drops the need for opioids. And in palliative care and hospice, I really think this needs to become one of our standard treatments, because when people are transitioning and their family members want to have quality time with them, the more opioids we give, the more we depress them and the less they're there. The other thing that we've been shown with this is that there's like this elevation of their spirit through the process, meaning they're able to focus better, they're able to have better cognition. We know that in depression, there's a lot of stuff out there. I'm not a fan of these websites that are selling S-ketamine where you get on a Zoom and someone ships you ketamine in the mail. That's not my jam. This is not something to be messed with. Like, this is something that it really needs to be done in a way that is going to be able to maintain our knowledge as we move forward. So when they looked at the efficacy of racemic epi, which is the S-ketamine, and intravenous ketamine really is the best treatment for refractory depression, the IV form, which means it's got to be done in a clinical setting with the appropriate monitoring, with the appropriate, in the appropriate setting. This is one that I just came out March of 2020, and I don't know if we use ketamine in the ER here for suicidal ideation, but this was a randomized double-blind trial, 18 individuals. They gave 0.2 milligram per kilogram ketamine IV. 20 minutes post-infusion, 88% of the people that got the ketamine were out of their suicidal period, compared to 33%, which is again where you would expect with placebo, and then sometimes just coming to the ER and talking to someone, you obviously have that piece. But this shows that ketamine can be used in the emergency room setting for acute suicidal ideation. This is the most recent one. This is from the British Medical Journal, February of 2022. And what they did was they looked at patients that when they came in, again, prospective randomized, the 63% of the participants that got the ketamine had full remission, and that went out to 69% that had it 6 weeks later. Only 31% of the placebo arm, again, back to placebo effect, which is about 33%. So it's not just that it treated the depression, it's not just that it got them out of that suicidal ideation, because when someone is suicidal, it's very difficult to talk to them and to reason with them. So this finding indicates that ketamine it has rapid onset. So within 90 minutes, you're able to see that change in that patient, and it's something that I think is going to become much more accepted mainstream. My concern is there are a lot of ketamine clinics popping up all over the world. I had someone call me to ask me if and when I was opening a ketamine clinic in Sedona, because they were going to drive 2.5 hours. And I'm like, there's ketamine clinics right where you live. And ketamine is one of the drugs that can be an abused drug. And so this isn't something where someone would walk in the door and say, hey, I'd like 120 milligrams of ketamine, please, and I'll come back next week and get the same thing. That's not what this is. This is using ketamine as a tool for medication-resistant depression. I want to talk briefly about MDMA. MDMA is also called Molly, it's also called ecstasy. It is the first drug that will most likely gain legalization in a therapeutic setting, and it's set to happen sometime in 2023, according to MAPS, which is the Multidisciplinary Association of Psychedelic Studies. The majority of research with MDMA has been done in our veterans, because PTSD, I don't know if you know the stats, but 40 veterans a day take their life because they cannot live where they are, and the medications that we have do not touch it. Just kind of like the antidepressants aren't touching the depression for cancer patients. These individuals are living in constant pain. So what the study showed was it was 3 guided sessions. It's definitely more of a therapeutic session. There's the pre-session, the MDMA 3 sessions, and then the integration. 67% of the individuals in there no longer met the criteria for PTSD. And it was not just out to 2 months, we're out to 18 to 24 months. These are game-changing interventions, and they're not for recreation. You heard that already. So the results of, I'm going to show you a couple of clinical trials that are just about to report their results. These are all from clinicaltrials.gov. Phase 2 single center, fixed dose, 30 patients. This was for major depressive disorder following cancer. And they recruited the patients. They measured every possible antidepressant, anti-anxiolytic scale that they possibly could. I'm very excited to see this because this was with a single dose, 25 milligrams psilocybin, and it was an open label trial. This one out of Utah, the results are expected this month. I looked again last night, they still weren't out. And this is an interesting concept because we know that group connectedness, particularly in our breast cancer patients, we know that it can decrease risk of recurrence. We know that it increases mood when you connect patients that have a similar journey. That's why for a lot of the veterans, they do very well in group therapy, because only someone else that's been shot at and like had the same experience can actually feel that. So for cancer patients, I believe that the group process is going to become very, very popular. So I'm very excited about this because obviously these are not going to be inexpensive treatments, and to be able to treat 4 or 6 people at the same time I think is going to be amazing. And even if you do individual psilocybin sessions, doing those group preps and the group integrations. So this is a study that had 12 groups, 4 to 6 per group. They did 3 prep sessions, a psilocybin session, and 3 integration sessions. And I'm excited to see these results because these are the results that are going to be able to take us to that next level to be able to do phase 2 and phase 3. This is a phase 2B trial. It just opened this month, looking at psilocybin in advanced cancer. It's from NYU Langone. This is the Ross group. These are trials that are open, and patients from Philadelphia can go to New York to participate in this trial. So this is something that when we have cancer patients that are stage 3 or stage 4 that are really suffering, and there's nothing that we can do for them, we can offer them access to these clinical trials. So this is a trial using 25 milligrams of psilocybin in the treatment arm, 1 milligram in the placebo arm, and they're enrolling 300 people. So they expect this to be done January of 2027. And this, I just put this up so you can see the exclusion criteria. It's pretty strict. This is about safety and efficacy. This is to prove the efficacy, we've got to be able to maintain the safety. And each individual obviously has to be assessed psychosocial, emotionally, and also physically. So the primary outcomes that they're looking for this are the anxiety and depression scores. But I also thought it was interesting that they're looking at, I didn't even know there was such a thing as a demoralization score and change of life attitude score. And they're looking at these at baseline, week 8, and then at 6 months later. So they're really looking to try to see what are the long-term effects of this for patients. USONA is an organization in Wisconsin. They are the company that makes the psilocin. So psilocybin is, or psilocybe cubensis are the mushrooms. Psilocybin is one of the components. Psilocin is the synthetic component, and that is what the trials are being done with the synthetic component. And starting this summer, we're going to have a phase 3 FDA trial, and this is for all comers. This isn't just for cancer patients. This is going to be for major depression. This is another trial that I'm hoping we can participate in. We meaning me, not and my colleagues that I'm working with in this space. But to me, this is going to be an important trial because this phase 3 trial will then allow us to get compassionate use or expanded access, because right now veterans can get compassionate use and expanded access for the MDMA. This is something that I'm really hoping we're going to be able to get with psilocin, because there are a lot of people that are suffering that standard medications do not work. If you've ever been around someone who's depressed and they take an antidepressant and they say, being on the drug is worse than not being on the drug because I don't feel anything, nothing makes me happy, nothing makes me sad, I am numb. And many antidepressants increase suicidality as well. So this is the deal here. You know, we have a huge number of patients being diagnosed with cancer every year. This is this existential distress that every single diagnosis of cancer comes with. It doesn't matter whether you talk about it or not, it's there. And a third of those that get anxiety and depression, you know, our current treatments just aren't doing it. So we've got to continue to move forward. This study, which was published just in September of 2022, was looking at, you know, the high unmet need and why it's so important. And I think anyone in this room that treated a patient with cancer during COVID recognizes that all of these issues were escalated worse with the isolation. Not being able to go to support groups, not being able to have their loved one in the room with them, having to wear masks, having to do all the things that we did. And I believe that it's going to have a significant impact on healthcare overall. I think it's going to be nationally. I think the United States is working very, very hard to do this. This is like crossing the I's, dotting the T's, checking all the boxes, because if it's not done with that level of acuity, we're going to lose the ability to have these very, very important, what I think, transformative medications for the patients that it's appropriate. So like I told you in the beginning, setting, preparation, trained sitters are a must. Integration is absolutely key. And I am not supporting recreational drug use, just as a reminder, so thank you. Questions? All right, there's gotta be, okay, Gene Salkite.
Are any of the novel therapies that you talked about in standard chemotherapy?
Are any of the ones I talked about in standard practice?
No, what I'm asking is, are any of the different ones, like psilocybin, are any of them better to start than?
So the reason why psilocybin has kind of been the go-to for cancer care is that it's incredibly effective at depression, and because the depression that comes along with cancer doesn't have the same response to medications, that's what brought it to the forefront, because it was an unmet need. You can't have someone who's depressed and you give them a pill and they get worse, or they get nothing at all, which is why when they started doing this research again back in the, in the 80s and 90s, back in when they'd done this research at Aquilina Cancer Center, they went for psilocybin first because, number one, it's a naturally occurring substance. The mushrooms grow out in the woods. There was enough anecdotal evidence to show its efficacy. It's incredibly safe as long as you stay away from, the hypertension and the family history of psychosis and bipolar 1 and all those things. And because it's not addictive, and it's not something like someone's gonna, and we also believe that there is a place potentially for microdosing. So I don't know if you're familiar at all with the concept of microdosing, but that's what that 1 milligram of psilocybin is in those clinical trials. That is not a therapeutic dose. Nobody gets an effect from that, except for some people, that microdose has been able to maintain their state of well-being. And so that's why there's a lot of, if you're watching the legislation going on, there's a lot of laws going to, it's called decrimination, the decriminalization laws, where psilocybin is being, it's not criminalized anymore. You can't go out and sell it. You can't, you can't be using it as a physician in a clinic, but people that are able to utilize it in their low dose to maintain their well-being, they're able to do it. And I think that's probably going to continue. Now, in California, Oregon is actually, it's going to be legal in Oregon for therapy starting in 2023. And that's one of the things with all the coursework that I'm taking and stuff. Those states are making those legislative changes so that practitioners can provide these treatments without fear of losing their license. But obviously in the state of Pennsylvania, I think medical marijuana is legal here, but nothing else, I believe. So anything that's done has to be done in a clinical trial, but I think to your answer, psilocybin is, to me, the drug, the entheogen of choice that's going to be used in cancer care because it's effective with the anxiety and the depression, and it doesn't have bad side effects. Yes?
What is the difference? I mean, this model of depression is related to cancer. So what's different sort of pathophysiologically between depression related to cancer and depression related to other traumas in life? Yeah.
Right, so this is one of the things that we talk about with the ACEs, with people can be very good at packing their bags of all their stuff and walking through life. All their previous stuff is packed away. And unfortunately, like when cancer shows up, it unpacks the baggage right in front of them. I don't know, we all know depression is not a serotonin deficiency, so that's why SSRIs, I don't know how they ever got them through the FDA to begin with, but they're not fixing the problem. And the effect, the lack of effect in cancer patients, I don't think they've ever figured it out, why it is. They just know that in trials, it just comes from a different place. And I don't know if that depression comes from a combination of this existential crisis, or the fear of death, the anxiety of who's going to take care of my family, God forbid if I'm not there. How am I going to go through the rest of my life? Because I've said this all along, someone gets cancer and everything changes for them. Every single thing changes. But if they look normal and they have their hair and they're showing up at work, the rest of the world's like, oh, they're back, they're fine. But it's never quite the same. There's BC, there's your life BC before cancer and life AD after diagnosis. And they're very, very different lives. And that's the piece of cancer care that, that's what's drawn me to look for something else to be able to help and our patients to get to a place of healing. Yes?
I have a question, and it kind of piggybacks on the question that was just asked, so what is the difference between, we all have pain and trauma and suffering in our life and then get a cancer diagnosis. I mean, nobody gets out scot-free. But I thought what was really interesting about what you were discussing early on in the talk was using ACEs to evaluate adult patients. Because we know, I think, in the worlds of psychology, certainly in education, that adverse child experiences impact how human beings learn, how they take information, how they respond to information, and how they respond to any sort of stimulus in life itself. So do you know if there is any standard for in any health system in America for evaluating ACEs in adult cancer patients?
I have not found that as a standard protocol, but it's something that I think we need to begin to elevate that knowledge, because like I said, I know that people come into cancer with their baggage, but I never actually looked at it completely like that until I started studying, entheogens and their place in cancer care potentially. And when you look at how it's kind of like, we ask people to, well, you can't just keep sweeping some things under the rug. And I think that's what happens with cancer. Cancer makes you feel your mortality, and I think it then makes it harder to suppress the other stuff that you might have been able to have the fortitude to suppress again. And I don't know that for a fact. This is just me looking at how do I want to practice medicine differently going forward, because I've always been focused on healing, but I also know that from my personal experience with our patients, we do healing retreats, 3 and 4 day retreats. One of the things that I really got out of all this training is that there is a form of breath work. You can call it holotropic breath work, you can call it shamanic breath work, you can just call it yoga breath work. I got more insight into where I'm going in my future through that breath work than I did through the ayahuasca, which may sound interesting, but I think that was my gift, because if I'm going to be able to bring this work into health systems right now, if I can get doctors on a retreat and get my colleagues to do breath work, there's nothing illegal about it. It's easy to do. You have to follow directions. It's probably the hardest thing for us to do as doctors. But if you are guided in that breath work, you then have the ability to have that experience and to gain that knowledge, which until you do it, it's hard to describe. But we added breath work to our first retreat we did in Sedona in 2019, and I will tell you, 15 out of 15 women that went to that said that 4-hour experience was one of the most impactful experiences of your life. That's what our patients are saying in these clinical trials. With the clinical trials with psilocybin, these individuals are saying that 65% of them said it was one of the most impactful experiences of their life. 35% said it was the most impactful experience because they created a connection. It doesn't matter what their religious or belief system was beforehand. They got this newfound sense of connectedness to the divine that they had to have. Even people that were like proclaimed atheists, they then said, well, there is something else there. There's a higher power. I can't put a finger on it. I'm not going to run off to church on Sunday, but there was something that they gained from that experience that gave them insight into who they really are. And to me, that's kind of priceless, because anything that we can do in our world that connects people instead of dividing us, I think is really important right now as well, because, thank God we don't have to turn the TVs on anymore and watch ads. My state of Arizona still hasn't figured out who's won races. They're still arguing about it, and it's like it'll probably be that way till January, till someone gets sworn in. But just the fact that there's so many ththings dividing us, that I love the fact that now we have the opportunity to help bring people together, and it can be through breath work. It doesn't have to be through an entheogen. And not a lot of research has been done in breath work in cancer care, but it's something that I really also want to bring forward because it's safe, it's effective, and it's a do it now kind of thing. I don't have to wait for any laws to pass to do it. We can give patients and caregivers that opportunity. So I think we should do a Spark Breathwork Day. I don't know about you guys, but once we don't have to wear masks, because it's really hard to do breathwork with masks, I'm just saying. So, other questions? Anne?
Just, excuse me, if they've shown the efficacy of the ketamine, and we use ketamine all the time, like, are we using it in cancer patients now, or why not?
It's, a lot of places aren't using it in cancer patients, and to me, anything that can drop the amount of narcotics we can use, that was one of my reasons for kind of wanting to do this, because I don't know exactly what we're doing here with our home care, with our hospice program, with our palliative care program, but these are things these are kind of do it now things, like that, the studies on that refractory pain, it's so powerful that you can use a small dose that's just hitting those, MNDA receptors, and you can drop the opioid requirements. And personally, from my perspective, I would love that if my loved one is transitioning, they can be out of pain, but they can be clear. And so, it's legal, we can do it. I am happy to work with whoever to set up a program to start it here, to try it, because we can be one of the first, cutting edge centers to add, this fringe proven therapy, I also know that there are a lot of cancer patients who had depression going in that are finding a lot of relief with IV ketamine therapy, as part of their care plan, and that's where ketamine clinics, having the right support, having the right physician engagement, not just being able to walk in, tell them what dose you want, get IV ketamine and leave. That's not what this is about for me. For me, this is about having that relationship with the patient and finding out what works. But I would love to be able to look at our, also if we have less narcotics that are going for palliative care, there's less risk of diversion, so. Did you learn anything? Do you think I'm crazy, Mike Lane?
Comment on that.
No.
So are the slides going to be available?
Yeah, the talk is gonna be available. I'll give the slides, you can have them as a PDF if you want. And the thing is, this was an introduction. This is introduction to a really different world, which I never, if you had asked me in November of 2019, would I be standing here at Redeemer doing a talk on psychedelic therapy? I'd say, you lost your mind, because LSD is evil. I don't believe marijuana should be legalized. I think that there's Karen, I know you're looking at me. I think there are places for it medically. There's a lot of places for CBD, but I also believe, marijuana to me in a lot of young undeveloped brains is a gateway. And it really scares me that we have gone so far to legalize it, and we're missing, 30% of these kids can have a psychotic break and not come back. That's a little scary to me. And but medical marijuana for pain relief, CBD, I'm all for it. I just, it's too much of a good thing sometimes. I believe that the regulations around the work that we're doing is so important, because I think it needs to be able to be accessed by patients, because it can really change the quality of someone's life. We might not be able to change the quantity of their life, but we can change the quality of their life. And that is, we care, comfort, and heal here, as far as I know. That's been my jam ever since I came to Redeemer. Way back when, I was like, oh my gosh, they actually care about healing. What a novel idea. So I think we can be on the forefront.
So are we considering anything going through our IRB? And that's the way we have to put it on.
I'm considering it, but I needed to do today before you would consider it. No, and the thing is, what I want to do is I want to do the trial on breast cancer patients in conjunction with Johns Hopkins, because they've got a lot of experience with it. My people that trained me, Mary Casamano and Bill Richards, they've been doing this forever. They've been doing this for the last 15 years, and they do it really, really well. But I think that we really are positioned to be able to do this and get funding and bring it to the forefront.
So I apologize for your instances. Any academic center in our region doing this? I assume the Glasgow is still doing Jeff.
Not Penn, I'm for sure, I can tell you that. I don't think Jefferson is. No, I'm surprised because NYU Langona's doing it. I mean, there's programs at Harvard and in Boston.
Is MD Anderson doing it?
Not that I know of. But I will tell you that Jenny Grana was all over this when I gave my talk last year, and I talked about this. She's like, we need to do this. We need to get on this. Like, this is cutting edge. This is healing. This is transforming, because we can give the right cocktails or drugs, but when we don't go to that next step, we're doing what everybody else does. So I think it's an opportunity.
Are the pain management societies on board?
Yeah, there are a lot of there are a lot of programs in Arizona. I will tell you, the closer you get to California, Oregon, all those states, they're very much on board with this. I just think that it's something that until that seed was planted in my brain in 2019, I didn't go out searching for this stuff. I kind of do what I learned in conferences and what I had learned in my training. And literally, I meant it when I said it. Once you see, you cannot unsee it. Once you see the effect and the ability to impact someone's life in that way, and I've met enough cancer patients now who've gone to do their journeys, some through clinical trials, some through going to other countries because they were in such a bad place. And then they come back and they say, oh my God, this saved my life. This was the game changer. And so for us to potentially be part of changing that game going forward, I operated yesterday here and I love to operate. I'm a good surgeon. I can keep cutting out cancer till my hands fall off or until the nurses put me in the corner because I can't operate anymore. But I will only take care of this number of patients. For us to do this work in this space of providing this high level of healing for our cancer community, we get to impact this many people. So that's what I still want to do. So
I highly recommend the book and the Netflix.
Yeah, the
When
book-
She first talked to me, I was like,
Lynn's like, no way.
Oh my God, like she's really going off the deep end. But it's fascinating for
Well,
anybody who's.
I would just say, thank you, I think you've shared that with me. I've known Beth now for a while, and I guarantee you, I said she had to smoke pot and take LSD, and she was.
Never.
Clearly then I learned that she is not there, so for her to move in this direction, in my opinion, is sort of trusted, because.
My dad had a lifelong subscription to the Limbaugh Letter. That is where I grew up. My dad was a cop. My brother-in-law was a cop. Drugs are
I
evil.
just didn't believe it at first.
I know. But here's the thing. When I read the book, I didn't believe it. When I pulled the papers and I read the science and I started to see the accounts, that's when it really resonated with me because I said, you know what? This is how we change our standard of care, how we change our practice. My practice in breast cancer care has changed completely over 35 years. We didn't hardly do anything the same way, and we got there by clinical trials. So for people to be walking around in a tie-dye t-shirt, I've never done LSD, but I understand you put the thing on your tongue, I don't know, you put a little thing on your tongue. That was not anything that was ever, I never had a desire to do that. But now I have a desire to take this piece of cancer care and escalate it so that we actually can really be looking at mind, body, and spirit for our patients and get them to a good place. So I'm glad you came, Michael Lane. Thanks, everybody.
Thank you, Dr. DuPree.